So thank you, Domenico, for this nice introduction. Thank you so much for inviting me to this great congress here in Chile. Actually, I want to talk more about GI disease and not microbiome and barrier function. So the topic will be gut barrier function and immune tolerance in healthy and allergic dogs. I have nothing to disclose concerning to this presentation. To give you a short overview, I want to talk about mucosal immunology and inflammation, but only from a perspective of a clinician, very briefly. And then I will focus on the intestinal barrier function. And in the end of my presentation, I will talk about potential risk factors for the development of chronic enteropathies, because nowadays we already have 4 studies showing that an acute intestinal injury can progress to chronicity also in dogs. More than 20 years ago, one of my main mentors, Mike Willard, he performed a great study, a wonderful study, because he sent slides from biopsy samples from dogs with chronic enteropathies to different histopathologists, and he wanted to see the agreement between them. And there was an outcry in the world of gastroenterologists, in the veterinary world, because there was such a substantial inter-observer variation detected at this time, and it was not suspected. And we also know that clinical signs and histopathologic inflammation description does not correlate well. But why is it so challenging to assess the degree of inflammation in the intestinal mucosa? And what is the difference to other mucosal sites like the respiratory tract or the urogenital tract? I think that's very obvious, and we have already heard it. We have this enormous antigenic load in the intestinal lumen by the ingested food on the one hand, and on the other hand also by the trillions of microorganisms. And they must be tolerated to maintain the mucosal homeostasis, but still the immune system is in a permanent alertness and always in a mode of a defense mechanism. And that's the reason why we have so many lymphocytes, plasma cells, and immune cells in the intestinal mucosa, more than in the bone marrow, in the spleen, in the lymph nodes. The intestinal microbiota, as you can see here in the lumen, in the feces, and the intestinal mucosa, they build one unit, and they are considered as one organ system. And we know from germ-free mice, for example, if you don't have any intestinal microbiota, the immune system is underdeveloped, so we do not have a lot of immune cells. But with the number of bacteria in the intestinal lumen, also the number of immune cells raises, and in some textbooks this is already referred as a physiologic, a controlled inflammation in the GI tract. And that's the reason why it is so complicated for a histopathologist to distinguish between what is a normal inflammation and what is already uncontrolled. So in my opinion, because there's so a bad correlation, we have to switch away from primary look at inflammation, because there are more important topics. And I think we have to switch, for example, to the transition phase from acute to chronic. We nowadays have a very clear pattern of acute intestinal disease. For example, dogs with uncomplicated acute diarrhea, they improve within 3 to 4 days, and even after 7 days, nearly no dog shows any clinical signs anymore. So what do we do with dogs which show diarrhea after maybe 10 or 14 days? I think that's a critical phase, because this might be the progression to the chronicity. And maybe this is the time when it might be reversible. We already have a lot of research in intestinal microbiota, fecal microbiota transplantation, and I think that's very important and it should go on, but I will not focus on this. But I think not enough sufficient attention is put on barrier function and on intestinal mucosal function. And we heard some explanations and on barrier function, but still I want to go through some of the slides. So we know that it is obvious that the outside world has to be a barrier has to be between the outside world and the inner world, so that we do not have a passage of bacteria and detrimental toxins through this epithelial lining. And for this, we have a composition of an intestinal barrier which is composed of a luminal defense mechanisms, of a physical barrier, and the lamina propria with its immune cells. And the normal commensal bacteria microbiota consists of different species and taxa. It's very diverse, and it is also kept in a very small limit. So if we have too many bacteria, we call this a bacterial overgrowth. And in a bacterial overgrowth is also some form of dysbiosis and can also trigger inflammation. And we see this sometimes in dogs, for example, with exocrine pancreatic insufficiency, because they have a lot of substrates in the intestinal lumen, and the lack of pancreatic enzymes, and these enzymes have the ability to suppress bacteria, such as other substances like biliary juices and gastric acids. So the number of bacteria have to be kept in a certain limit. But not only the number is important, also the composition of the intestinal microbiota is important, and we call this normobiosis. And the commensal bacteria is responsible to suppress so-called pathobounds. That means these are bacteria which have the potential to be pathogenic, for example, if they release some toxins, and they can be present in a low number, but if we have an overgrowth, this can be a problem for the host. And so we have, again, different substances like bacteriocins or bile acids, secondary bile acids, and also pH modification, which suppresses so-called bacterial pathogens. And we have a very nice illustrative example from human medicine for luminal defense mechanisms, and this is the Clostridium difficile infection. And maybe you all know that if a patient is in hospital and he receives antibiotics, then you suppress the physiologic, the commensal bacterial flora. And then this is the chance for pathogens to overgrow, and in this case, this is Clostridium difficile. And with this overgrowth, there is a release of toxins, and these toxins can destroy the mucosa and lead to mild diarrhea, but also to a life-threatening fulminant colitis. So this is a very good example that the physiologic intestinal microbiota is protective against bacterial infection. We do not see the same disease in dogs, but we have a very similar mechanism or pattern. And we performed a study where we wanted to show the association between the intestinal dysbiosis and the prevalence of Clostridium difficile, which is also called, and I hope I can say it, Clostridioides difficile. And we know from also from the studies from Jan, and he has invited this dysbiosis index, we know that about 60% of dogs, they have 60% of dogs with chronic enteropathies, they have a dysbiosis, especially based on this dysbiosis index. And this dysbiosis is characterized by a lack of Clostridium hieronymus. And Clostridium hieronymus is a beneficial strain, very important because he is the main bile acid converter. And if this bacterial strain is decreased, we have not the conversion from primary to secondary bile acids, and these secondary bile acids would be necessary to suppress the growth of Clostridium difficile. So that's a very constant mechanism seen in human medicine and also in dogs. And this is one figure out of our publication, and you can exactly see that if you have a normal number of Clostridium hieronymus on the left side, these dogs with chronic enteropathies, they will be Clostridium difficile negative. But if you have a reduced number or a completely lack of Clostridium hieronymus and no bile acid conversion, then you will have a Clostridium difficile positive dog with chronic enteropathy. So I think we learned a lot, because if you find Clostridium difficile in a dog with chronic GI signs, this does not mean that this is a primary pathogen. This more or less reflects that we have an intestinal dysbiosis in this case, and for this reason this bacterial strain is present. So in summary, the luminal defense mechanisms, there is very important that we have a healthy and stable intestinal microbiota. The second line of intestinal barrier is the physical barrier, and it consists of a mucus layer, as we already heard, and one line of cells, the epithelial cells, and the mucus layer is very important, is a very important component of the barrier function, because the mucus prevents the direct contact between the bacteria and the intestinal epithelium and the intestinal mucosa, which they do not like if bacteria really stick directly on the epithelium. And this mucus protects it by several mechanisms, for example, by its stickiness. It's also binding to some receptors to decrease microorganisms penetration. And the mucus also has a stream away from the epithelial cells into the lumen, so that there is no direct contact. And it is also very interesting to see that the goblet cells which produce the mucus, they also react to the intestinal bacteria. So some substrates like short-chain fatty acids, they stimulate the mucus production. And we have two distinctive layers, one loose outer layer which still contains bacteria, so it's a habitat of bacteria. But we also have a very dense inner mucus layer which is devoid of bacteria, so this is sterile. And it is kept sterile by different components like defensins, but mostly also by IgA, so globulins, they directly bind to primary pathogenic bacteria and destroy them. I already explained that there is a relationship between the number of bacteria and also the production of some substances and the thickness of the mucus. And we know that the thickness of the mucus is much intenser and thicker in the large intestine, because we have much more bacteria in the large intestine compared to the small intestine. And if we have a destruction of this mucus layer, as we might see in acute diseases or in chronic diseases, this means that the bacteria have a direct contact to the epithelial cells and also are very close to the immune system, and this might be already enough to stimulate the immune system and to create some milieu of inflammation. The epithelium is a very important part of the physical barrier, and it's a one cell layer, and if we have intact epithelial cells, they prevent the transport through the cells, the transcellular route, but also between the cells we have the tight junctions. We also prevent that macromolecules diffuse across this epithelium, but these tight junction complexes are very important to dynamically regulate the solute transport and also the electrolyte transport. And we already heard a lot about the immune cells, the lamina propria with these immune cells. But very shortly, very briefly, this very important system with these many bacteria in the intestinal lumen, this is very challenging for the immune system, of course, and therefore we have an immune system with a dual purpose. That means, on the one hand, we have to defend the host from bacteria, especially pathogenic bacteria, and therefore we have this effector compartment, which consists mainly of these lamina propria mononuclear cells. But on the other hand, we have to maintain this mucosal balance and to regulate the inflammation, and therefore we have this inductive compartment, the gut-associated lymphoid tissue, which consists of bile patches and other lymphocytes. So this was only briefly a little bit about immunology and barrier function, but now I think it's important, I want to talk about potential risk factors for the development of chronic enteropathies. And maybe you know that there are three main mechanisms discussed which might trigger chronicity, and one main factor is the barrier dysfunction. And you know this barrier regulation hypothesis, that means if we have a destroyed barrier function, then we have an increased translocation of food components and maybe bacteria, and the immune system will be overwhelmed, and then this might trigger inflammation and also a breakdown of oral tolerance. And besides the barrier dysfunction, also a stable intestinal microbiota is very important. And we already heard yesterday that also early life events are very dangerous, because we know that young individuals, puppies, but also babies, they are fragile because the immune system, the microbiota, the barrier function is not fully developed. And so if we have an early life event, this might have significant consequences. We already heard from Domenico that there is a difference between allergies, adverse food reaction, or food-responsive diseases. We believe in human medicine, in people, that the prevalence of food allergies is rising, especially in the westernized societies. And we think this is connected to the diet, to the westernized diet, which is high in fat and low in complex carbohydrates. And we also know there is a little bit of a shift of the intestinal microbiota. So this in combination might be one reason why we see that we have so many allergies in humans in this Western world. But we also see a lot of dogs with cutaneous signs and do adverse food reactions, up to 25%, and we already heard it in the previous presentation. But even more dogs with chronic diarrhea respond to a diet. So we see every second dog is responding to a diet, and I believe they are not all allergic, because we have so many different other components of a good diet nowadays. For example, the digestibility, also if we have fibers in the diet, and then the barrier function is improving. But still, this shows that we see a lot of cases responding to diet, and maybe there is an immune component behind it. And now I want to switch to a dog model for acute intestinal damage, where we see a barrier dysfunction. So this is the acute hemorrhagic diarrhea syndrome. And I just wanted to show you a typical case. That's Nora, a mixed breed dog, female spayed, 4 years old. And this dog had hemorrhagic diarrhea since 12 hours. You can see the typical fluid loss and the hemorrhagic diarrhea. And in these dogs, we see that this has a sudden onset. We have a dramatic loss of fluid and a significant damage of the intestinal mucosa by Clostridium perfringens. So some toxins are released, and then we have a necrosis of the intestinal mucosa. The good thing is that this is a self-limiting disease if we give enough fluids and symptomatic treatment. But as you can see on this video, we have a significant destruction of the epithelial lining of the mucosa. We have this hemorrhage in the mucosa, and we can see this all over the intestinal tract. It's in the large intestine, and this is also in the small intestine, and this is already the ileum, and in the large intestine. So a huge surface is destroyed. If we take a biopsy, we can see that we have a necrotizing enteritis. We know from the blood in the feces that there is a breakdown of the GI mucosa blood barrier. We see this bacteria attached to the necrotic villi, and so we know that we have a dysbiosis in these cases, but also very interesting is this dysbiosis is only transient. After a couple of days, after 1 week, they are normobiotic again. But we think that these dogs have a significant barrier dysfunction. You know, we have different methodologies to assess the barrier function, the perfusion not the perfusion, so the barrier function. And so, for example, multi-sugar tests or biomarkers like lipopolysaccharides or sonulin, but all these tests are not very good validated in dogs in veterinary medicine, so we are not using them on a routine basis. But recently, we think there's an improved assessment of the intestinal permeability by iohexol, which is a contrast medium, and this test is already validated, and we have reference ranges for iohexol when we measure it in the blood. And we performed a study where we wanted to test the intestinal barrier function in dogs with acute hemorrhagic diarrhea using iohexol. So immediately after admission of these dogs with acute hemorrhagic diarrhea syndrome, we rehydrated them and we gave them about 2 milliliters per kilogram of iohexol orally. And then 2 hours later, we took blood and we have frozen this blood, and then we sent it to a special lab, and by ELISA, the iohexol concentration was assessed. And as expected, we saw that we have a higher serum iohexol concentration in dogs with AHDS compared to the healthy control dogs. And also there was a correlation between the degree of the severity of the disease, so the disease activity index, and the concentration of the iohexol. But I think most important for me was to see that we have a subgroup of dogs. As you can see here, they really had very high serum iohexol concentrations, and these were the dogs with a very severe disease and a very high AHDS index. So there's a subgroup with a significant barrier dysfunction, and so these dogs fulfill all the risk factors for the development of chronic disease, because we have this transient dysbiosis in these dogs, we have this necrosis of the intestinal mucosa, that's the colonic mucosa here, so we have an increased risk that allergens can cross the epithelial barrier, and then they can overwhelm the immune system and trigger maybe a breakdown of the oral tolerance. So our next step was that we wanted to follow these cases, and I will present some similar studies now, but every study has the same concept. That means in the dogs with AHDS, we were searching in our database for these dogs, and then we followed them for several years, at least for 1 year. And for every dog with AHDS, we also needed a control dog. So, for example, if we had a 4-year-old Rottweiler, female spayed, and this dog had acute hemorrhagic diarrhea, then we were looking for a similar dog, so also a Rottweiler with 4 years, but was presented for a vaccination, for example, so did not have any diarrhea cases or significant history of AHDS previously. And then we followed both and sent a questionnaire to the owners, and then we wanted to know how frequently they developed chronic disease later in life. And it was very interesting to see that in the AHDS group, we found out that nearly every third dog, 28% of dogs, they developed chronic GI signs later in life. And this was significantly different to the control group, which only had chronic diarrhea in 13% in this group. And chronic diarrhea means that they showed diarrhea longer than 3 weeks. So I already mentioned that early life events are important. So AHDS is primarily a disease of adult dogs, so the middle age is about 5 years old. But now we wanted to look at younger dogs, because we know the young individuals are very fragile, and the reason is that the intestinal microbiota is not developed, the intestinal tract is leaky, so we have to build up the barrier function, and so we have this very fragile phase in infants and in newborns, and we think that's the same also in young dogs. So this early life is very important, and we have to avoid significant impacts to really maintain an optimal long health and resilience. So we switched to another dog model, and this dog model is the canine parvovirus enteritis. Again, fulfills all the requirements for barrier dysfunction because we have the significant necrosis of the intestinal villi, and we also have most of the time a significant dysbiosis because these dogs have a significant acute disease on the one hand, but on the other hand they all receive antibiotics. And the difference to the HDS dogs is that these are usually very young dogs. These are puppies. And so we did the same study design in these dogs, and we followed the canine parvovirus dogs, and we identified that nearly every second dog which survived a canine parvovirus infection, they developed chronic disease later in life. And this is again completely different to the control group where we saw only 12%. And I was very happy that this study was performed also in another country in, I think it was in Canada, the study group in Canada. So they did the same study design and they had very similar results. So they found out that 57% of dogs after an episode of canine parvovirus infection, they developed chronic GI signs later in life in comparison to 25% to a control group. So what we can say nowadays is that if a dog has a significant disease due to parvovirus enteritis, they have a risk factor for chronic GI signs later in life. About every second dog will have chronic problems. And we also followed these dogs with chronic clinical signs after an episode of parvovirosis. And it was interesting to see that the chronic disease developed not immediately after the acute disease, so they improved, they were stable, but within 1 year they showed clinical signs. So the disease activity was not very high. We had an activity index of 5 of the IBD activity index, which can be considered as moderate disease. But again, very interesting was that most of these dogs, so 2/3 of these dogs, had a food-responsive disease. And this high number of food-responsive disease, they let us speculate that this might be reflecting an immune-mediated response, an immune-mediated disease, maybe a food allergy, because we had this breakdown possible of the oral tolerance because of the mucosal barrier dysfunction and the disturbance of the intestinal microbiota. Very recently we performed a study in Giardia, and the reason was that there is a study in human medicine. There was an outbreak of a giardiasis in Bergen in Norway, and more than 1,000 people were affected, and about 50% of these persons, they had long-term problems. They showed a so-called IBS, irritable bowel syndrome, after this Giardia infection. And also, if we take a history from a dog owner of a young dog, then frequently we hear that everything started with the parvovirosis infection, and then it continued to progress to chronicity. So our goal of this study was to evaluate the prevalence of chronic GI signs in dogs after Giardia infection and identify possible risk factors triggering this chronicity, for example, the treatment with metronidazole. And our hypothesis was that there is a high prevalence of chronic GI signs following acute Giardia infection. And I have to highlight that all of these dogs were symptomatic, so they had a positive test and they showed acute intestinal diarrhea. And we also hypothesized that antibiotic treatment might have an influence. And these are very preliminary results because this is not published, but it was again very interesting to see for us that about 1/3, so that's very similar to the HDS study, that 1/3 of dogs after clinical giardiasis, they showed chronic diarrhea later in life. And this was again higher compared to the control group. And I want again confirm that there was not a bias. So we really looked for an age and breed matched dog, and we sent the same survey to the owners, so there was no telephone call, so that might be influencing a little bit. So it was really strict. So I believe really in this data. And it was also interesting that we also asked for dermatological signs and for pruritus, and also there was a difference. 33% of the dog owners had the feeling that the dog showed chronic dermatologic signs, and this was again different to the control group, where we saw this only in 8%. So in summary, I think we really can see that in dogs, an intensive intestinal injury can progress to chronicity. We do not know exactly the mechanisms, if this is really an allergy, but with the last slides, I just wanted to discuss or start a discussion with you which potential strategies we have to start for preventing these long-term consequences. So what are the next steps during this acute phase of enteritis? So maybe first we have to confirm that acute enteritis and barrier dysfunction is really leading to chronic problems and allergies. And in this case, maybe we should give a hydrolyzed or elemental diet already in the acute phase. Maybe we have to consider if we have a very significant barrier dysfunction, for example, in a dog with parvovirosis, to treat more with parenteral nutrition. We should try to restore the intestinal barrier function. And that means we have to give early enteral nutrition to build up the barrier function more rapidly. Maybe we have to look for more specific nutritional management. For example, we should maybe give some nutrients like glutamine, butyrate, or fibers also in the acute phase, not only in the chronic diseases. And maybe we also have to look for pharmaceutical components which improve the barrier function, like the mucus layer. We know that several drugs, medications, they can affect the barrier function. For example, proton pump inhibitors, NSAIDs, non-steroidal anti-inflammatory drugs, as well as antimicrobials. So we should avoid them also in acute diseases if we don't need them immediately. And we should consider eventually to modulate also the intestinal microbiota in some cases, but we need some more studies. But at least in parvovirosis dogs, we have some data showing, at least in the acute phase, that an FNT is beneficial. So what are the next steps maybe to prevent the transition from acute to chronic? I think we should put our focus on this phase when the dog shows diarrhea, maybe after 10 days, and then maybe we have to be more aggressive in the diagnostics or maybe in the treatment during this time, because this might be a phase where it might be reversible. Most of the time with chronic disease, we only manage the disease. We have an ongoing progressing disease, and it's not reversible, so we have to detect them very early. So we also have to stress a little bit to improve the health prevention strategies. So we started a growing dog project in Zurich. That means we will follow young dogs, puppies, lifelong, and the goal is to establish early markers of chronic diseases in general, and especially for chronic enteropathies. So we have to detect this disease already in the subclinical phase, in the early phases, and maybe the dysbiosis index might be one of this marker of early disease in the intestine. And we also need new markers, or better markers, and sensitive markers to detect intestinal barrier dysfunction. So I will summarize, and it's very simple, that I believe that acute intestinal disorders can lead to long-term consequences, not only in humans, but also in dogs. And the suggested triggers are intestinal barrier function, intestinal dysbiosis, and also the time is very important, so we should take care of our young patients. So thank you so much for your attention. And I want also to say thank you also to my collaborators, Jan Suchodolski from the Texas A&M University, and my colleague in Munich, Katrin Busch, and especially also all my group in Munich, the team of the health prevention, the team of the gastroenterology, and also the whole internal medicine team. Thank you so much.